Welcome to the final webinar in the Parkinson's Foundation Expert Briefing Series for the spring. Hello, everyone. I'm Dr. James Beck, the Chief Scientific Officer at the Parkinson's Foundation, and I'm delighted to speak with you today. As you know, April is Parkinson's Awareness Month, which makes today's webinar even more special. Our three-part webinar series this spring has been devoted to symptom management, where we ask the question, is it PD, is it medication, or is it aging? We're thrilled to continue our symptom management series with mental well-being and memory. We'll be hearing from our expert presenters, Dr. Greg Pontone from Johns Hopkins University, and from Lisa Cohn, a Parkinson's Foundation research advocate and a person who lives with PD herself. But before we begin, let me remind you of a new option to listen to our expert briefing series. Starting with a series of expert briefings this spring, we have been making webinars available in Spanish on our YouTube channel, Canal en Español. It takes about 4 weeks for our team to get the translation ready to review, and our first one on motor symptoms is already up, and the second expert briefing on non-motor symptoms should be ready shortly. So let's take care of some housekeeping first. First, I'd like to thank our sponsor of the Winter-Spring 2021 Expert Briefing Series, TheraBiopharma. It is with their support that we're able to present this engaging series of webinars this spring. So thank you very much for that support. Now let me share with you how to navigate around our screen here. So at the bottom of the screen, you'll see a chat icon and a Q&A icon. So chat icon is where we're going to be pushing out information to you. So my colleague's going to, for instance, push a link to download the slides for today's webinar. You can find them on our website too, but for those who'd like to download them and print them out and have them in front of you, you can do that. Also in the chat will be a link for continuing education credits for those who are interested in receiving free CEUs for watching this webinar, and you know who you guys are. So if you're interested in one of these free CEUs from the American Society on Aging for viewing this webinar, click on the link now and save it into another browser window. The link will also be in your follow-up email after this webinar as well. So if you miss it here, you can also get it later. So regarding the CEUs, you only have 30 days. So that's until May 20th, 2021 to collect your free CEU. And as always, this expert briefing is being recorded and will be available in about a week, probably the end of this week, for all those registered today. And you'll receive an email with this link as well. So if you really enjoyed it, want to go back and watch it again or share it with some friends, feel free to do that. So now I want to find out a little bit more about who's listening today. So if we can go to our poll slide, what we'll have here is a poll. We're looking to find out what best describes your connection to people with Parkinson's, sorry, your connection to Parkinson's disease. So if you're a person on Facebook, feel free to enter in the comments, which of these categories best represents you. If you're watching on Zoom, a poll should have just showed up on the screen. Select the whether you're a person with Parkinson's, a spouse, partner, scientist, nurse, or other, and hit submit. And we'll find out briefly, get a quick sense of who's watching our presentation today. It's always fascinating to see who's here. Not surprisingly, we have a lot of people, 50% people with Parkinson's disease, 20% roughly are spouses or partners. We have a lot of healthcare professionals today, about 15%. So that's really great to see, as well as some nurses and nurse practitioners. So hopefully everyone will get a lot out of today's today's presentation. And that leads me to our next order of business, which is for me to introduce our presenters. So on our screen today, you can see Dr. Greg Pontone and Lisa Cohn. Gregory Pontone is an associate professor and director of the Parkinson's Disease Neuropsychiatry Clinic in the Departments of Psychiatry and Neurology at Johns Hopkins University School of Medicine in Baltimore, Maryland. After completing his internship and residency in psychiatry at Johns Hopkins, Dr. Pontone then completed a 2-year fellowship in geriatric psychiatry and movement disorders, focusing on Parkinson's disease. This was offered through the clinical research program of the Morris K. Udall Parkinson's Disease Research Center at Johns Hopkins. This is a prestigious designation by the NIH for Johns Hopkins. Our next presenter is Lisa Cohn. Lisa Cohn was diagnosed with Parkinson's disease in 2008 at the age of 45. Since taking an early retirement from her work as an executive in the field of healthcare services, she's used her professional experience as well as her personal experience to aid her work as a volunteer patient advocate. She's been working as a Parkinson's Foundation research advocate since 2015 and was a participant in our Women and PD study. Lisa has co-authored 2 published research articles and is active in advancing patient-focused public policy issues. In July of last year, she was appointed to a 3-year term on the Foundation's People with Parkinson's Council. She lives in Denver with her husband and 3 dogs. Greg, Lisa, welcome, and I'll turn it over to the both of you.
Right. Hopefully you can hear me. I'll go ahead and get started. The first thing I should let you know is that I don't have any financial relationships with commercial entities relevant to this talk. I have been a consultant for the following companies. The learning objectives for today are really to just describe and talk about normal age-related changes in your cognitive abilities. I mean, this is people with and without Parkinson's. This is what we can all expect as we age. And then strategies to stay well. And then I want to talk a little bit about medications that might cause cognitive impairment in Parkinson's so that you can be aware, because many times they are the culprit. And the good news is they can be modified or removed to restore function. And then we do want to talk a little bit about how Parkinson's disease itself might affect memory and other types of cognition as the disease progresses over time. And so with that, we're going to launch into a discussion of wellness and mental health. So you probably have heard this term wellness, and I've often asked myself, what is it? Well, there's actually a very formal definition. The World Health Organization defines health as a state of optimal well-being and not merely the absence of disease and infirmity. And so the traditional healthcare model, at least here in the United States, really only focuses on the bottom half of this concept of health, right? They have traditionally focused on illness and the symptoms of disease and making those better, right? Whereas wellness is really the top part of that definition, or raises the ceiling a bit and talks about what it is to be happy and have a higher quality of life. And it's an active pursuit of activities and choices that you make that lead to this state of health. And so, I want to ask Lisa, because wellness is a very personal thing. Lisa, what is wellness to you?
Thanks, Greg. I like the idea of wellness being a journey as it's been presented here. And I think this would be true with normal aging and life changes, but it's particularly true for people with Parkinson's, in my perspective, because what wellness is today, 13 years later, is not what wellness was the day I was diagnosed. At diagnosis, I'm sure my definition of wellness would have included some degree of keeping up appearances or keeping up with the work I was responsible for, because that was a lot of my identity. I had to leave the workforce in January of 2013. And since then, I would say acceptance is a huge part of me feeling well. So some days I can't do everything I want to do, and I have to give that to myself without judgment. And the days that I have energy, I try to fill it with the things that give me the most pleasure. Being outside in beautiful Colorado, spending time with family, playing with my 4-year-old grandson, working in the yard, or doing these kinds of volunteer activities. But I think it's how I feel about what my body's giving me.
Okay. Yeah, I think you made some great points there. And let's give everybody an opportunity to sort of chime in. We've got a poll here that talks about how much do you feel your mental well-being affects your quality of life compared to the degree of physical impairment you might suffer.
This will be interesting.
Okay, we'll give people a few minutes to answer. Certainly, like I said, everybody has their own perspective on this. And as you mentioned, it does change over the lifespan for most people. And it'll be interesting to see what people say. Ah, okay. So it looks like the majority of people do think that their mental well-being affects their quality of life more than their physical impairment. Okay,
Mm.
that's good to hear because
Mhm.
it's easier to change your mind sometimes than it is to change other things.
Yeah, agreed.
Okay, so let's talk a little bit more about wellness. Uh, Wellness, I think, really is a verb. You know, it's something you do, it's an action. You can't just be well. It's a pursuit and a lifestyle. And this is basically a model developed by Dr. John Travis. And it goes from the disease, right, even all the way to death, disability, symptoms, and signs, to a higher quality of life. Okay, and that's what wellness is literally that continuum from illness to your optimal state of well-being. And I think what Lisa said is really important. That optimal level is going to change depending on where you are in your life, whether you've been diagnosed with certain conditions, what your economic, social resources are at the time. And so this is a very fluid thing. And that's why the pursuit of wellness has to be an active process, okay? Because you're going to have to be flexible and adapt to the changes that life throws you. And I mean, sometimes, life throws you good things, right? And then other times not so good, okay? The one thing that I think has been left out, though, of this traditional model of health and wellness is mental health. And the times when it's not left out, it's unfortunately been the target of stigma. How many whispered conversations have you heard about high blood pressure or diabetes? People talk about that very openly, right? They talk about their family history of those things. Hey, my grandmother had
Mhm.
diabetes. Oh, yeah? When did she check her blood sugar? You don't really talk about mental health that way. If someone has depression or if they've had things that make them, quote unquote, anxious or psychotic, those things are more often a whispered conversation. And, in my career, I have to tell you, I've thought a lot about why that stigma exists. Part of it, I think, comes from many, many years ago. In fact, I don't want to blame anybody, but there's this idea of mind-body dualism that I think comes from Rene Descartes. And it was the idea that the mind was separate from the body. Okay. And, now today we know that, the mind is a function of the brain, which is an organ within the body. And we know that if you keep your body healthy, your mind generally follows, and that they're interdependent. And I think that when you can begin to think about mental health and mental illnesses in the same continuum, that stigma will be reduced. And Parkinson's, I think, is the best model for this, because we know that changes in your brain are the cause of your movement abnormalities. And we can be even more specific. It's a change in the level of dopamine. Well, in the case of things like depression and anxiety, changes in other neurochemicals like norepinephrine and serotonin are probably the mechanism that causes depression and anxiety. And I think if more people would start thinking of mental health and mental illness this way, you wouldn't be so reluctant to talk about this with your doctors, with your family, or who knows, maybe one day even in public. And so again, I just think I want to put that out there, because these mental health issues occur more frequently in Parkinson's than they do in people who don't have Parkinson's on average. And so you really need to be able to get them out in the open to deal with them. Okay. Now, the other thing I want to talk about is cognition. And the first way I want to talk about cognition in mental life is the way it affects all of us, whether we have or don't have Parkinson's. Okay. Because if you don't know what normal is, you don't know what the Parkinson's may or may not be contributing. And so if you look at aging and its effect on our mental function. The first question you should have is, what stays the same and what can I expect to decline? Well, there's two types of memory called procedural and semantic memory that are generally well preserved with normal aging. Okay, procedural memory is how to ride a bike, okay, how to cook an egg in the morning. Semantic is more how we use words to convey meaning of events and then store them in the brain. And I'll talk a lot more about memory in upcoming slides. But believe it or not, as you age, normal aging, these things should be well preserved. Okay, now here's another good one. Vocabulary and your general knowledge of the world remain stable or even improve by, you know, a couple tenths of a standard deviation per decade through the seventh decade. And so again, that's, you know, this doesn't mean that everything's declining. There's actually something to be said about wisdom. And I think, you know, wisdom definitely comes with aging for most of us, you know, and visual perception of objects remains stable. So now people say, well, wait, that can't be true. How come, you know, how come I'm having more fender benders? Well, you know, visual acuity might decrease, right? So if you have uncorrected vision, that might be the culprit. But in terms of visual perception, you might actually be more accurate. You know, like I remember when my grandfather said, hey, it's about, you know, 30 meters to the pond and I'm off by 10 meters. And then we go measure it, you know, we have a gentleman's bet and he's right. And so there are certain things that are completely intact and maybe even a little better. And then language is stable, at least until age 70. Okay. So this is, you know, I think mostly good news. This is normal, healthy aging. Okay. Now what changes? And remember, this I'm talking about both, you know, for everyone, but also in Parkinson's. So for everyone, your ability to sustain focused and to divide your attention decreases with age. Okay, it decreases a little bit more for Parkinson's than the rest of us, but it's decreasing for all of us as we age. Working memory, that's the ability to sort of take things and manipulate them before you store them as a memory. Okay, it's like your work table. Okay, that degrades a little bit with normal aging. Okay, executive function, that's our ability to organize, sequence, and plan and do what we call set shifting, going from one activity to another. There's a little bit of an inflation, there's an increased cost of doing that as we age, and that cost is even greater in Parkinson's. Okay, processing speed declines for all of us. We can still get the right answer, we might just have to reflect a little bit more. And in Parkinson's, the processing speed is also down, maybe even just a bit more than it is for the rest of us with normal aging. And then here's the thing that I want to throw out there as a caveat to everything I've said so far, is that with quote unquote advanced age, most cognitive domains change. Now, what do we mean by advanced? 80, 90, 100. And look, the bar keeps going up. You know, we're aging better as a society. So I just put advanced for now. I don't want to put a number on it because you've probably heard the old saying, age is just a number. And so, you know, Lisa, I've said all these things and I just, you know, this is from textbooks, but I want to get your take on this.
Yeah, that's a lot to unpack, isn't it? Well, let me just tell a little bit of how this has gone for me. So one of the first symptoms, well, of course, what got me diagnosed was a tremor, but it was pretty early on when my body told me that if I was under stress, my performance would change. And so I had indicators that it actually took the intervention of my movement disorder specialist to tell me that's stress, Lisa. And I thought, it wouldn't have been last year. And, you know, so I began to notice these changes, and I referenced earlier leaving the workforce, and I left the workforce because of my cognition changes. And so I began to notice that giving a presentation was a challenge for me because it was more difficult to organize my thoughts. And I had a long history of giving presentations, and they'd mostly be very, not ad-libbed in that I didn't know what I was going to say, but very comfortable, like what we're doing here today. And I began to ramble, and I'll try not to do that today. But I also noticed things like doing planning spreadsheets. I couldn't get all the data right. And it was frustrating to me because I would articulate this concern to others and nobody could see it at this time, except me or except the people who were right closest to me, who spent the most time with me. And I was not even sure what to make of it. So I sought out a neuropsychologist who gave me, many of you who are people with Parkinson's will recognize this. MoCA is the acronym for the kind of simple cognitive test that you may have had in any kind of routine medical appointment. And what the neuropsychologist did with me was much more thorough, hours of testing. And what it did for me was actually just made me feel better that I was changing. Like there was this difference in how my brain worked. So I had to leave the workforce because of how my brain had changed. And I didn't know anybody at that time. I too thought Parkinson's was a physical decline. Like my departure from the workforce might have been from one of the physical manifestations of Parkinson's, but for me, it was the mental. And it was around this time that I began to realize I had more in common from a cognitive perspective with my parents than I did with my peers of my own age. So when I would talk to them and I'd lament and they'd say, oh, me too. And I would be, that's out of order. And I think it's probably underappreciated in how we're treated.
Okay. Yeah, no, I have to tell you, I think that's a great description of probably executive dysfunction, especially given you're an executive. This flies under the radar, like you said, for a long time. I think your mention of the fact that only the people closest to you noticed it initially. And, that's the case many times. We hear from family or care partners that something's changed. The one thing that we do in the office, or most people do in the office, is they give these little brief assessments. So you mentioned that you got the Cadillac, you got the fancy whole neuropsychological battery, which is really the most specific way to test each domain of cognition. But a brief screening is this Montreal cognitive assessment that I know everyone's seen here on the screen. And it really, what's nice about it is you can see the boxes, name the domain of cognition that it screens. Okay, now look, most of the time people are going to either ceiling these tests or have problems in just one or two domains. So really all they are is a screen. And I always tell people, you may have one bad administration of the test, and I say we never make anything out of one bad test. We like to see a sort of pattern or trajectory of change. And so if you're asked to take one of these quizzes, I always tell people just relax and do your best, and it'll sort itself out, over visits. Now let's see. The other thing that I think we should talk about, and this is sort of what's recommended, and I want to let you know this isn't just a casual recommendation. Everything on this list has been scientifically studied. So these are things that have data behind them. So most people, when I tell them, hey, you can do things that will decrease your risk of cognitive decline, whether you have a disease like Parkinson's or not, the thing they assume I'm going to say is brain games or puzzles, right? New York Times crossword puzzle. It turns out that as of today, best evidence across many, many studies is that physical exercise, particularly aerobic exercise, has shown the best benefit to globally improving cognitive ability. And look, when I'm talking to people who have Parkinson's disease, this is a win-win, because the only disease-modifying therapy currently shown to slow or decrease the progression of Parkinson's is also physical exercise. So this is absolutely what everyone should be doing. And the parameters of exercise, you should talk about it with your doctor so you're doing it in a safe way. But there's no question that this is going to benefit you. The other thing that's really interesting is, some people like the brain games and the puzzles, but you don't necessarily have to do those. I mean, some people just attend lectures or do educational activities that require mental effort. I mean, this can be Scrabble, it can be, almost anything that engages your brain. Okay, video games. There's increasing evidence that video games increase both your processing speed and your visual spatial perception and reaction time. Okay, so if you have grandchildren or children, give some of these a try. Social interaction. And so this is, literally just going to dinner with a group of friends or having them over for, a campfire, who knows, engaging in activities in your community. In fact, there's been a formal study of how social interaction affects your memory. So list learning activities have been shown to improve in people who are social compared to those who are not. And to me, that's amazing. So in people who are social, they score a few points higher on list learning memory tasks than those who aren't social. And so this really has a huge impact on your cognition, but also your emotional sort of well-being as well. So again, almost everything on this list, there's a 2-for-1 benefit as we go down point by point. And then I save sleep for last. And not just because it's usually the last thing all of us do each day, but because sleep may be the biggest point on this whole slide. If you exercise, you need to recover. If you learn something new, you need to consolidate those memories, right? And so sleep, a minimum of 6 to 6.5 hours per night is the recommendation. And I'm just going to keep repeating this as I go through the slide set because it's that important. I can tell you that, during my training, how little sleep you could get and still function was a bragging point. You'd come off a call, an overnight call, and you'd say, the nurses kept me up all night. I got 2 hours of sleep, and your hair's, I don't have hair, but I did that. And, and you'd brag, and then your colleague would kind of one up you and say, well, I didn't even get to put my head on the pillow. And it turns out that your next day would never be good, and you're taking care of people. So they've actually changed the call frequency for most physician training programs now, because sleep, the thing it most damages is your ability to pay attention and to do, executive tasks, like, manage people's medicine and make sure their lab results are good. And so again, if you have Parkinson's and that, attention and executive function is vulnerable to the disease, that makes sleep an even higher priority. You also have to think that, like I said, when you learn new things, sleep is probably the integrator of new memory. Okay, that's one of its jobs. Okay, we don't know everything sleep does, but we know that that's one of its jobs. So we've even shown that people who learn a list and then take a nap versus people who learn a list and don't remember more of the list for having napped. Nothing else, just the nap. Sleep is important for brain metabolite clearance. So as we learn more and more about what causes cognitive decline and aging, cognitive decline in Parkinson's, cognitive decline in diseases like Alzheimer's, it turns out that the glymphatic system, so you've heard of lymph nodes and lymphatic system for the body. Well, the brain has something called a glymphatic system, which is the trash man. And so when you start to accumulate bad proteins and metabolites and toxic things, when you sleep is when they're best cleared out, is part of what we think is happening as well. So you have to give yourself this sleep opportunity to take out the trash, so to speak, to clean out the dirt, okay? And so unfortunately, as we age, there's many more things that might impact the quality of our sleep. And so what can you control? If you have sleep apnea, if you have other, pain related issues, if you have Parkinson's and your medications wear off, some of that's out of your control. But what you can control is your habits. And so what you need to do is make sure that you give yourself a quote unquote sleep opportunity of at least 8 hours every night. And what I tell people is it's as simple as deciding a consistent time that you want to wake every morning, and then a pretty consistent time that you want to go to bed each night. And don't let anything interfere with that. Maybe the occasional holiday or celebration, but otherwise, you want to give yourself that opportunity most of the year, every day. Okay. what are some of the reversible causes of cognitive impairment? So, aging, obviously, we don't have an answer for that yet. Parkinson's, we're working on one. We're getting closer. The dominoes are falling, but we still need some help. So what can you change? Well, certain sleep disturbances, like sleep apnea that I mentioned, can be improved significantly by using a CPAP machine. Vitamin B12 deficiency or low thyroid hormones can be corrected by your doctor, and it's a simple blood test, and you can know if you have these things. People often ask me, should I take supplements just, in case? And I say, well, you could, but they haven't been shown to do any justice to you unless you have a deficiency state. So if you do have a deficiency, absolutely. If you don't, I mostly advise people to save their money. Depression. So depression's a big one. In fact, severe depression, not only can it impair your cognitive functioning, severe depression can masquerade as dementia. I can't tell you how many times we've had people come into our inpatient unit with quote unquote dementia, and we treat their depression, and all of a sudden they're thinking normally again. So this is certainly a reversible thing that can be impacting your cognition. And then medication side effects. And we'll talk about those at length in a few minutes, but repetition's the mother of retention. So some of these are over-the-counter things like anticholinergic medications. Benadryl's a big offender. And so this is definitely something that both you personally, in terms of the over-the-counter, but working with your doctor, should keep an eye on. Very important, and definitely something that's under your control. And then now I want to move a little bit to be more Parkinson's specific. And so there's a few cognitive domains that are definitely impacted by Parkinson's disease. And one of the most common, most frequent, and earliest changes in cognitive function that people with Parkinson's notice is what we call executive function. And when you start to have trouble with this, and I think Lisa's example was perfect, it's subtle at first. You can still do everything. It's just not as sharp, right? And there's not as much margin of error. And so your ability, again, I'll say, to organize, sequence, plan is slowly eroded, okay? And I think one of the best ways to demonstrate this is through a research study that was done. And basically, I like to call it the Let's Have Tea study, because part of the task, you had to carry a tea set on a tray. And really the study was to look at how divided attention, remember I said none of us divide our attention well, none of us are good multitaskers, and if you have Parkinson's, you're especially bad. This was basically the study, or one of the studies, that proves it. And so this study looked at how attentional demands during everyday functioning contributed to performance and gait disturbances. And so they took people with Parkinson's disease in the mild to moderate severity, right? About 20 of them. And then they had 20 people without Parkinson's as controls. And they basically had 4 tasks. The first task was just simply walking between a mock kitchen and a mock living room, okay, in the testing room. And they would time everybody. And of course, people had times that were, personal to them. Some people are fast walkers, some people are slow, but they needed a baseline time. And on average, the people with Parkinson's walked a little slower than the people without, but that's expected. That's part of what Parkinson's brings. Then they had what they call a dual motor task, which is where they asked people with and without Parkinson's to walk and carry a tray with the tea set. And they found that everybody slowed down a little bit when they were doing 2 things, walking and carrying a tray, right? But the people with Parkinson's slowed down a little bit more than the people without, okay? Then they did something interesting. They had people walk just as they did before, but now they wanted them to recall a list of words from memory. And it turned out that everybody slowed down, right? Because none of us are good multitaskers, but the people who had Parkinson's disease, they slowed down even a bit more. And then the real tell was what they called the multiple motor cognitive task. And this is walk, carry a tray, and recall a word from memory. And there was a disproportionate reduction in speed, gait speed, in the people with Parkinson's. Everybody slowed down again, right? Because none of us are good multitaskers. But if you have Parkinson's, the lesson here really is focus on one thing at a time to maintain optimal functioning. And I want to turn this back over to Lisa, because this is a very controlled example, and I just want to see how Lisa has noticed changes in her life.
I would ask first, was there tea in the glass, in the cup? Because that would certainly slow me down even further. Anyway, I want to comment on your stay well slide, and I want to add reduction of stress. So for me, that's been a significant contributor to my well-being and what I think of as my overall health. And to do that, I have to use some coping mechanisms because I know what's going to happen if somebody's talking to me and I'm trying to cook, and I don't, that's a normal transaction with people in your home. So I don't want, I have had experiences where I'm like, stop talking to me. I got to finish this and I can't do it while you're talking to me. And it could be as easy as just checking off a shopping list at a store, but don't talk to me while I'm doing it. But like one simple example, and I'll use that is in your home, is like cooking. So I learned that if I got all the ingredients out, and I understand this is how the French cook. I can't validate that, but I've heard this. So you get all your ingredients out, and as you use them, you move them, right? So if I got interrupted, at least I know what's done and not done. Because I one time made a 3-ingredient pancakes, forgot one of the ingredients, and I couldn't figure out what it was. And like 2 days later, in the middle of the night, I thought eggs. And those sorts of real activities can be super frustrating. And sometimes I just feel like I hit a wall and I'm like, okay, I'm done. I'm out. And I just want to add, to make the people who are listening feel better. I know Greg knows this. I just want to say we do struggle with good sleep. So I don't disagree with any of the recommendations, but don't beat yourself up if you're still having trouble sleeping. That's where you engage with your provider and you work on what it is that can improve that. But don't feel like it's a straightforward thing and you have somehow missed something if you're having sleep trouble, because that would not be true. Right, Greg?
Lisa, I couldn't agree more. So that's actually one of the kind of exacerbators of poor sleep, is worrying about your poor sleep.
Yeah. And I describe, like, so if my brain originally was this big, Parkinson's made it this big, stress makes it this big, so it's like I have just less to work with.
Absolutely. Yeah, no, I mean, I can't tell you how many times we hear people become more flustered when they're stressed or rushed. And so the other thing I think important point you make is, when you have a task that's important, make sure you give yourself ample time to complete it so you don't feel rushed.
Absolutely.
Okay. So I think the next thing that we should move to is another cognitive domain. And believe it or not, most people, when they think of memory impairment, they think of Alzheimer's. And for the most part, Alzheimer's is the king of the jungle when it comes to memory impairment. That is the domain that it owns and affects. But there is a little bit of a change to memory in Parkinson's, but it's got its own flavor. And so I just want to give you an example that will hopefully resonate with many people. So, I call it the file cabinet example, and it's been used by many people. And essentially, it's this idea that our ability to learn new information and then store it is like putting documents into a file cabinet. Because remember, in order to remember it, you've got to be able to find that memory in the file to retrieve it or bring it back out, okay? And so basically we call the process of learning new information and then storing it, we call that encoding. And then remembering, the process of bringing that information back out for use, is called retrieval. And that's really, even though it sounds like a couple of steps, that's an oversimplification. There's a lot of ways memory can go wrong, but let's say you had 2 people, okay? One with Alzheimer's disease and one with Parkinson's disease. And both of them, their wife's birthday was coming up. And they said, look, it's our birthday in 3 days. We want a cake. And they give them a recipe for baking a cake. Well, the guy with Alzheimer's, he didn't have a prayer because encoding is where memory goes wrong with Alzheimer's. And so he takes this 6-page recipe for a cake and he takes 2 pages, throws them in the air, takes the other one, rips it in half, crams it somewhere in the file and eats the rest. So the point is he never encodes it, right? Because his ability, his hippocampi are in bad shape. Now, the person with Parkinson's disease, though, by and large, and this has been shown on MRIs and many studies, by and large, the hippocampus, the hippocampi, that's the plural, are in good shape. And a person with Parkinson's can take that memory, those 6 pages, and they encode it just fine the majority of the time. They put it in C for cake, right? Everything goes well there. But the problem comes for both of these guys about 3 days later when it's their wife's birthday, right? The wife comes back and says, hey, it's my birthday. Where's my cake? Well, the poor guy with Alzheimer's, he can't find the recipe, right? He might find a fragment of it somewhere in the file. The guy with Parkinson's, though, he's got maybe a little bit of executive dysfunction. He's going to have a retrieval problem. He's encoded it fine. So he goes over to the file cabinet. There's 26 letters in the alphabet, right? So he just starts randomly looking. You know, he's in W, he's looking in Y for a while, he looks in A, and then his wife does something. She gives him a hint. She cues him, is what we call it. And she says, cake, starts with a C. He goes right to C, pulls out the intact memory, boom. So this is a hopeful message. That means in Parkinson's, with cueing or contextual cues, or just enough time, right? There's only 26 letters. He'll get to C eventually. The memory's there. And so one of the things I often tell people with Parkinson's and their families is don't rush them. So this is another case, gets back to Lisa's, don't be in a rush, right? Don't get stressed out. And the memory is there, okay? 9 times out of 10, the memory is there. And so here's sort of just a—
So Greg, ironically, I'm going to rush you.
Oh yeah, sure.
I think we have a lot more to cover and I understand we are running out of time.
Okay, absolutely. I will pick it up. So here's just a graphic of, yeah, I remember when you were talking about rambling, I was going to tell you rambling. But, you know, if you look at this slide here, the recognition memory and the free recall is down in Alzheimer's, and really recognition is great, you know, really good in Parkinson's, and free recall is only mildly affected. And so you can benefit from cueing. The next thing that we should talk about is other domains. And again, this isn't going to happen early in the disease. This would be, you know, at some point down the road for some people. You might notice that, you know, the memory problems we mentioned, or difficulty performing familiar tasks, like it takes longer to use the computer, trouble organizing your medications. Language deficits are fairly rare as well in Parkinson's, but occasionally you'll notice some word finding difficulty, or difficulty remembering the exact word you want to use. So you might say, give me the thing, or use indefinite articles. Time and place disorientation. Occasionally you'll get lost. Poor judgment, irresponsibility, forgetting appointments, those come along with that same territory sometimes. When you start to notice these are definitely the things, these are the flags that you want to go to your doctor about, okay? This usually means that something's changing and you want to have it investigated. Sometimes it's something reversible. Sometimes it's the progression of the disease. But when you see this type of change in function, this is where you want to go. So again, action items. Reduce distractions, focus on one thing at a time, exercise, stay social, stay connected. And then, you know, the last one here, stress reduction, is where I really have to turn it to Lisa to tell us a little bit more about what she does to combat some of these changes.
You know, I think one of my best coping mechanisms, and there are many, is just being okay with the times that I can't come up with my neighbor's name, who I know, right? And when I sound inarticulate because I'm saying the thing, you know, the thing, and I'm using hand signs. And so to help me cope with that happening, I have to just accept that it's where I am. Otherwise, I'm adding to the problem, contributing to the problem.
Yeah, absolutely. And you know, I think like you said, the important point is not to get flustered or panic, right? Just take a deep breath and keep going.
And, I'll be honest, it's part of my coping with Parkinson's is telling people. I felt some shame when I was trying not to act like I had Parkinson's, but I'm still forgetting words because people don't know what that means. And to me, it was helpful just to say, this is what's happening.
Absolutely. And then the next thing, and this is sort of the last segment of the talk, but I think it's really important, is how does cognition, what's the time frame of change in cognition? And so, one of our nurses who retired, who is great and just a great communicator, she would tell our patients, there are no cliffs in Parkinson's disease. Her name was Becky. Many of you probably know her. And she would say there's no cliffs in Parkinson's. And by that, she meant the disease is going to progress gradually over time. Okay. And if anything changes suddenly, like falling off a cliff, that's probably not Parkinson's disease. And I can't think of a better analogy for understanding when to go urgently to get medical help versus not to panic because it's probably just a gradual change of Parkinson's. And so for everyone, sudden changes in cognition over hours, days, or sometimes even weeks are usually not due to Parkinson's disease. Okay, they're due to something else. And that something else usually represents a medical issue that should be addressed with some haste. Okay, so the classic one is a delirium, which is an acute change in mental status, usually due to a medical issue like an infection, dehydration, bleeds in the brain, medication side effect, okay? And usually people will have a waxing and waning attention span or alertness when this happens. That is a medical emergency, okay? If you notice someone who's suddenly disoriented and confused, that's something you need urgent medical attention for. The other one is depression. Okay, it's not necessarily an emergency, but depression can cause a rather sudden change in people's cognitive ability. And the good news is, just like the things that cause delirium, it's reversible. Medication side effects are what I want to talk a little bit about. And I want to talk about it broadly because you don't have to be a pharmacist to help yourself better identify these changes. So if you know kind of 2 or 3 things about the disease, you can sort of figure out what might be causing the change in terms of medication. So Parkinson's disease, we all know, results in the loss of dopamine producing neurons. So anything that interferes with dopamine and makes it worse is going to worsen things. Okay, so some types of psychiatric medications, antipsychotics can do that. Okay, certain motility agents that we use for bowel motility can do that. Okay. Parkinson's disease is also associated with a lower level of acetylcholine, which is a brain chemical important for cognition. And that's the one that I would say is a big offender. So you can get a lot of anticholinergic medications over the counter. The 2 biggest categories are sleep aids, right? And Lisa just told you that almost everybody with Parkinson's has some degree of trouble sleeping. And so if you get that Tylenol PM, it has Benadryl, which is anticholinergic. So even the over-the-counter stuff you want to run by your doctor to make sure it's not going to cause a problem. The other type of anticholinergic medication that's ubiquitous, especially at this time of the season, allergy medications. Okay, they can often be anticholinergic and you can get them over the counter. And in Parkinson's, you're already starting from a lower level of acetylcholine and it can cause a problem. And then the third is anything that lowers blood pressure can be a problem with Parkinson's, both for cognitive ability, but also for your risk of falls, because it can cause you to feel faint if your blood pressure goes too low. So if you notice that you're having a feeling of dizziness, lightheadedness, or faintness going sitting to standing, and you feel mentally unfocused, it could be related to your blood pressure. And so sometimes people who have high blood pressure need to reduce or come off of their high blood pressure medications as Parkinson's disease progresses, okay? But again, this is something that you'll have a conversation with your doctor about. You don't have to worry about figuring this out on your own. You just have to be aware. And then this is something you can find online. the American Geriatric Society Beers criteria. And I put Beers on there just to be silly. It was named after a Dr. Beers who made the list, but who doesn't like beer? So I thought it'd be a good way to remember. So anyway, it's a guide, and you can look and it'll have specific medication names on there, so you can do a little sleuthing on your own. And then really, just to kind of go back and summarize a little bit the action items that you can do to stay your sharpest and, to be cognitively at your best, you need to actively pursue your own well-being. You should have a plan. I mean, this is, we plan where we're going to go to college. We interview and apply and plan for our jobs, but I don't think we do enough planning for our health and well-being. And this is what I'm suggesting, is that you really take time to just jot down a few ideas about how to be your best and how to pursue well-being, in different domains, cognitively, physically, emotionally, okay? You're not going to be able to control everything, but you can control the opportunity for sleep. And so give yourself at least an 8-hour sleep opportunity each night. Okay. And there are books and books on sleep hygiene and how to, make sure that you have the right environment for sleeping. I'll recommend a book really quickly. Matthew Walker has published a book called Why We Sleep. It's probably the most amazing resource out there for sleeping better and understanding the functions of sleep. Exercise. I wish I could have wrote that in gold, because exercise for Parkinson's, exercise in general, exercise for cognition, you will not lose when you exercise. It's going to help you physically, mentally, and emotionally. It's literally been shown to help with ailments in all 3 domains. So plan an exercise program that you follow most every day, if not every day. Stay social and intellectually engaged. This is not fluffy. Like I said, they've done tests of cognition that show that social people are intellectually brighter and sharper than people who are not. Okay. And then sudden changes in memory or thinking should be evaluated by your doctor. They could be an emergency. And then understand, and this is really one where I think Lisa's the expert here, understand your medications and the trade-offs they bring. So Lisa, just kind of go through this with us and tell us your thoughts.
I will, I want to briefly give a real life scenario that I think all of us will experience over time. So I take a medication, amantadine, for trying to help control my dyskinesia. And initially it was to help control my tremor. Well, my doctor in our appointments hears my trouble word finding, and she gets that that's frustrating. And so she suggested reducing my amantadine, which means I have to decide how much dyskinesia do I want to live with? How much word finding do I want to live with? So right now, I cut back my Sinemet and my amantadine, which means I'm slightly under medicated for all the Parkinson symptoms. And I'm slightly under medicated. Well, I'm taking 1/3 less amantadine. I still have word finding problems. And then, so I have to play with this. It's like, I have over the years had a number of images of what it's like to have Parkinson's, but my current one is walking a tightrope, trying to decide which way where I want to have either the effects of the having the medication or the absence of it.
Yeah, I think that's a great example. So, many of these medications we use have benefits for one set of symptoms and then might, decrease or cause trouble with another set of symptoms. And I think amantadine's one of the classic examples where, because it's a little anticholinergic, it can blunt cognition, but it's wonderful for controlling the dyskinesias.
Yep.
Okay. So I think as long as Lisa agrees, we'll field some questions.
I agree.
Everyone, Lisa, Greg, this was a great presentation, as always. I really appreciate the opportunity to listen to experts just talk about what they're doing and just get a sense of real practical information along these lines. We've had a number of really good questions come in. One of them, I think is interesting. It's a question from Hawaii, and we talked about this at the very beginning, Lisa, how you had neuropsych workup. And so, Greg, a good question for you is it worthwhile, trying to think about the changes that people might have when someone gets diagnosed? Is it worth to go through this effort? I mean, it's not inexpensive, I would imagine, especially if someone's younger diagnosis. When does one decide to do that kind of approach to understanding where they are as a baseline?
Yeah, absolutely. So one of the classic times is when there's a change. So if there's a change in function, it might be worthwhile to have one of those. And many times insurance will pay for it or pay for part of it. The other one is for candidacy for deep brain stimulation. We often like to have a cognitive baseline prior to that. But I do think that in the future, there may be a bigger role for neuropsychological testing, because as we develop more treatments, both behavioral interventions, like maybe cognitive rehabilitation, or medications that target specific cognitive domains, it'll be more important to know which domains are intact and which ones need a little help.
And Jib, let me add that I don't want people to feel like they need to go do that. I described the reason I went is maybe my hyper need for information. And if you are not in a position where you feel like you're anxious, just having it reinforced may not be the right thing for everybody.
Yeah, understood. And, this is a couple comments have come through here, and congratulations to Lisa, who's your, on many levels. One, just, being here to help provide that, the lived experience, but also, talking openly about your experience, dealing with some of these issues. How are you able to get comfortable on a presentation like this today? Did you, how are you able to prepare? Because I think, these are situations that our community is really interested in how to overcome.
I would say the first thing is, anytime I am the patient and I'm speaking in public, people that it's sort of like me being open about having Parkinson's. As long as I am talking as a patient and I'm not trying to present myself as an expert, where an expert should know their words.
Yeah.
Anytime that's how I have accepted that, I'm a patient, and therefore if I fumble, it's okay. I'm here to show that. In fact, I almost think it makes it, I don't do it on purpose, but it makes it more real when you can see that I'm moving around, or if I really got stuck on a word. But I will also say, I've got a little pinwheel of notes right here so that I have some reminders of what I wanted to say.
That's incredibly helpful. As we talk about, cognition, and the changes that people with Parkinson's face, one of the questions come in from a spouse who she feels her husband is having some cognitive issues. How does that conversation initiated? How are you able to convince someone that they have cognitive issues when they don't want to recognize it? And Greg and Lisa, I think this is a good question for both of you to how to deal with.
Well, I want to interject something here and definitely let Lisa say. So Lisa is a little bit unusual in that she would have been easy, as someone I was working with, as in my clinic. If someone said, "Hey, I'll have the neuropsychological testing," that makes my job easy because I don't have to convince her. She's looking for it, right? She's already self-aware. So, some people are going to be less aware of the changes, and then other people, and I think it was largely, and I'll let you speak for yourself, Lisa, but it had to be the demands of your job that probably made you more aware than the average bear.
I completely agree. I mean, the losses I had were absolutely required for the job I had, and I, as I said, I have a high need for data so that it helps me be more comfortable. I recognize some people probably don't have that high need. And it's, I've heard it said, if I don't take my blood pressure medication, then I don't have high blood pressure. And so I think for some people that the taking of the cognitive test might mean I have decline. So my best encouragement for caregivers out there would be to normalize what's happening. talk in terms of normal aging versus maybe an accelerated path, which is how I feel. So my path went, I went kind of from 50 to 70, but it's normal aging for somebody like me. And just recognizing it is such a relief. If I were trying to pretend that I didn't have these challenges, that would make my life much more difficult and much more stressful.
Yeah, for certain. It's it's illuminating to hear that too, because stress is one of the issues that people have been asking about, and I thought one a comment from one of the listeners who says that when she asks her husband a question, she gives him time to respond, gives him space to do so. I thought that was a very useful, practical tool to help people doing this. Greg, we talked about sleep as a real critical thing, along with exercise. I'd love to touch a little bit on exercise as well. But how, for people with Parkinson's, sleep can be difficult to come by. I mean, they can have daytime somnolescence, daytime sleepiness that they're battling, as well as issues of wearing off at night and things like that can keep them from getting good night's sleep. How do you advise people with PD to do that? Is it worthwhile to take a nap during the day? I mean, is that going to ruin their nighttime sleep? Short naps? I mean, what is your approach?
Yeah, so there's actually, I think you hit on the complexity. So there are many sleep problems that involve more than one issue. And so, a common one is that if your dopamine medication stops at a certain time, you may eventually begin to have wearing off in the middle of the night, and people will wake up, maybe not at first stiff and uncomfortable, but just restless. And they don't, it's subtle, it flies under the radar. And then later they might wake up because they get a Charlie horse or cramping because they're out of dopamine. And that can be corrected by working with the neurologist to fix the medication. But then sometimes people have too much dopamine and they're too revved up to fall asleep. And so it can be very complicated. But I think, at the end of the day, these are things that, I think Lisa said it best, there's always going to be some issue. And so it's really about giving yourself that opportunity and then not letting things interfere with that opportunity. And so naps are often a big question. And so it's been studied in many different protocols, but a short nap is probably a good idea because, Parkinson's is a very fatiguing disease. And so if you decide that you want to nap, I want you to be very deliberate about it. Meaning that it's not just catch as catch can. I want you to set a timer and I want you to try to more or less take that nap at the same time every day, because your sleep or rest efficiency during that nap will be improved by programming it in. And, half hour, 60 minutes at the tops is what we recommend.
That's useful. And Lisa, are you a napper?
One of my biggest issues is daytime sleepiness, fatigue, and then insomnia. And I'm a napper. I hear everything Greg's saying, and sometimes I just can't do I can know what's recommended. Apathy plays a role, like winter plays a role. I watch myself carefully so that I can decide, like, am I leaning into depression? Am I doing I have to self-assess all the time. What is happening right now? And at the same time, I think it's just really important to say, I can't be perfect about the recommendations. I do the best I can.
Yeah, I think that's probably the best thing is really doing the best I can. And I know our website, we have several fact sheets on sleep, and encourage our listeners to go there to find some useful tips, like satin sheets, so that help people turn over in bed. That can be very helpful along those lines. Exercise. So I just watching time. We've got a little bit more. If I can just have a bit more of your time, just exercise seems to be, as we've talked about often at the foundation, this rising tide that raises all boats. And it was really great to hear from you that it has such a positive impact on cognition. Do you think why is aerobic exercise so much better than someone who wants to do weightlifting or other types. And a question, again, I relate this to sleep, if I may. One of the questions that we came in from the chat was, someone can sleep, but they only sleep 4 hours. Is exercise a way to get people to kind of really fatigue and then be able to push that sleep a little longer than the recommended 6 to 8 hours?
Yeah, exercise can definitely help with sleep. So being active during the day is pretty highly correlated with sleeping longer and more restfully at night. Ideally, you don't want to exercise right before bed. You want to give several hours before so that your body can kind of cool down. So it turns out that internal temperature is important in our ability to initiate healthy sleep. So you want to be able to cool down after your workouts. Now, why aerobic? So there's a number of theories as to why, but that process and the intensity and the oxygenation of the tissue is all probably part of it. But it also turns out that aerobic exercise has been the most studied. So the other thing I want to mention that's really important is, while aerobic has the best evidence, it's very likely that resistance training, whether it's with weights or bands or body weight, and stretching, flexibility, mobility exercises are probably also helpful. There's just been less study of them. There's some idea too that aerobic exercise might trigger anti-inflammatory cascades that might help on a molecular level with some of these symptoms and maybe even disease progression. But more experimentation has to be done to know the exact mechanism. But I want to be clear, we're very confident that it helps the overall disease.
Agreed. It's a great tool to help with symptoms. We're well over. I've got one more question, if I can. Just regarding medications, is there, as people go on and off, does that lead to fluctuations in certainly cognition? I would imagine, and maybe in mental well-being. But I'd love to hear your both of you your feedback on that.
Yeah, I would like to hear what, if Lisa, if you're a fluctuator, kind of what your experience is, and then I can tell you the little bit that science knows.
I would say I know very little too, because it's just hard. It's trying to decide when I can think well, in comparison to when I take my medications, is a real challenge. But to the well-being part of your question, I can remember when I delayed taking any sort of dopamine replacement or agonist. And when I started, I had this feeling of euphoria that I didn't realize I had lost, because it just happens over time. And I just called it, I said to my doctor, I just feel better. There was no description. And so I think it's important to recognize that when we don't have enough dopamine, we're not going to feel optimal. And that was a number of years ago, but it was eye-opening to me that I was like, wow, this is what it feels like. Okay.
Interesting.
Yeah. So, I can definitely tell you that with fluctuations and the medication, the on feeling when your motor symptoms are controlled versus the off when your dopamine levels are declining and your motor symptoms return, is an almost inevitable consequence of disease progression. Most people will have some degree of on-off fluctuation over the course of the disease, being more common as the disease goes on. Now, this is what's interesting, is regardless of what it's doing to the motor symptoms, its effect on cognition seems to be different depending on the cognitive domain. So there's certainly some cognitive domains that do better in the off state, some that do better in the on state, and there can be an overdosing or underdosing of dopamine in certain areas of the brain. Because remember, your brain is losing dopamine in a differential pattern. Okay, it's not uniform across all the brain regions. And so, that's why I wanted to start with your experience, because I would inevitably say something and you'd say, nope, I'm the other one. And across my patients that I work with, everybody's response is variable. Some people they only notice the motor changes, and other people say, no, I feel a little fuzzy headed when I go off, or I can't concentrate and focus when I'm on. I feel like I have ADHD.
Thank you. And I know we had a number of questions we weren't able to get to, so I encourage you to just reach out to our helpline, 1-800-4PD-INFO. We have a lot of really expert counselors online who can help answer some of these questions. I want to thank Dr. Greg Pontone, Johns Hopkins University, Lisa Cohn, Parkinson's Foundation advocate, for your time today. Wonderful presentation, and I look forward to hearing comments as they come in afterwards. So thank you very much. I appreciate that. And so now we're coming towards the end. I would like to just thank our audience here, and just a reminder for those of you who are looking for our presentation based upon, for CEUs, check our chat. There's an email that's going to come afterwards that will have links that you will need in order to complete, get this credit. There will be a quiz as part of this link, and remember, you have till May 20th to obtain your free CEU. Our recordings are going to be made available in about a week, and in Spanish, it takes about a month to get it just right, but the end result is really fantastic. Oops, going too far. So this is a wrap for our spring series. We've had our 3 topics we've focused on about symptom management. We're going to pause here for and resume come September 1. That's a Wednesday, when we'll continue our expert briefing series. But that's not the end of opportunities for webinars with the foundation. You can always enjoy our 3 times a week PD at home programming, when we have Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays as part of that. And also, in addition to the resources of our webinar, there are a lot of things available on our website. We have a series on cognition that's been archived. We have fact sheets, medication guides to the many of the medications and potential side effects that Dr. Pontone talked about, as well as our podcasts on that as well. And then we've got our resources. Key one is our helpline, 1-800-4PD-INFO, as well as some other materials. But as we end our webinar, I don't want people to go anywhere. When you close the link to this window, there's going to be in your browser will be a pop-up for evaluations for this webinar series. Your feedback is really important. We use it to improve our webinar year after year to make it quality programming that everyone comes to expect. So really appreciate everyone to complete that. And with that, I will bid you adieu until September, and look forward to seeing people hopefully getting out into the sun, enjoying the warmer weather for us all. Take care, everyone. Bye-bye.